doing that, but it does require to have extensive testing and broaden testing out, actively looking for cases, and dealing with all of the other strategic issues that other countries. In principle, Morocco is in a strong place to continue control measures, and also be in a strong place with any restrictive measures, as long as Maria has said that that's done gradually, as long as that's done with great care, and as long as the other public health things are in place. But I'm sorry, I don't have a detailed set of data for Morocco in my head, but if my memory serves me, that is where Morocco is epidemiologically at the moment.
Thank you very much. Hope this answers the question from Morocco. Next question is from Devex, from Sarah.
The virus and doesn't have access to a test, how long after that can a person have the illness and be contagious? And then in terms of the reactivation in people, based on your previous response, is it possible for the virus to be latent in someone, or are we talking about reinfection?
Thank you for these questions. So yes, what we recommend for somebody who is exposed to an infected person is that they be followed, that they be quarantined for 14 days. Most people who are infected with COVID-19 will develop symptoms within 5 days. That's the median time, 5 to 6 days. But it goes up to 14 days. So 14 days is a good marker. For individuals who are infected, your question was how long can they be contagious? And that's the right question, because when we actually test people who are infected with COVID-19, they have this molecular test, a PCR test, and they can be PCR positive for weeks. But that doesn't actually mean that they're contagious for weeks. So what the PCR does is it measures fragments of the virus, parts of DNA of the COVID-19 virus that is detectable through this test, but it doesn't actually mean that you're contagious for that long. What we've seen from some preliminary studies, and I'm referring to a study from Germany, is among some mild patients, I believe it was 8 or 9 mild patients, that they could find live virus for 8 or 9 days after symptom onset. What we need is much more data from countries to actually be able to say how long is someone contagious. And so right now what we have are these PCR tests which suggest that people with mild disease can be PCR positive for 2 to 3 weeks. What we need to understand is out 2 to 3 weeks, are those people still contagious? And so again, this is another example where we don't have the full picture, but there's a lot of studies that are underway to give us those answers. And so we hope to be able to get back to you with more details on that as soon as they're available.
On the issue of reactivation latent, there are many situations, particularly in viral infection, where someone doesn't clear the virus entirely from their system. It can happen in the case of immunocompromised people who are sick for other reasons, and then the virus can come back and attack the person again, and that's sort of seen as reactivation of the virus, but develops a secondary infection, a secondary bacterial infection, often in influenza, for example. Not the influenza infection that causes the problem, it's very often the secondary bacterial pneumonia. The damage to the lungs and the inflammation creates opportunity for bacteria that are normally non-pathogenic, they're all over the place, but can actually exploit the fact that the lungs are weakened. And you end up then with a very high fever again and very sick, but you're actually not sick with the virus, now you're sick with the bacterial infection. So there are many reasons why we might see reactivation of infection or with another infectious agent. The issue of long-term, I think, transmission has been dealt with by Maria. There will always in health be exceptions. There will always be individuals who may transmit for longer. There may be individuals whose incubation period may be for longer. It may happen. There are outliers in every walk of life. We all know people who are given a year to live because of a cancer diagnosis and they live for 10 years. That doesn't mean that everyone with that diagnosis lived for 10 years. It means one person has lived for very much longer, but on average, this is how long people survive. And I think we need to look at that. These are averages, and then we look at the range around the average, and we try to explain that this is likely where the most the longest or the shortest incubation periods are in reality, but there will always be a chance of an outlier. And I always say we need to study the outliers. We need to who transmit for longer. We need to study those who have don't clear the infection properly, because these are very significant events. But we also have to be able to make good public health policy, and we have to try and make the best possible estimates of what is a reasonable incubation period that incorporates the vast majority of people, and reasonable transmission periods that incorporate the vast majority of people, and at the same time look at outliers, examine them, why they're occurring. And that is the work of science, and in the end you've got to translate science into policy. You've got to translate all of that data into a rational policy that can be implemented for public good.
Our policy actually is, it may be helpful, and this is based on the science that we have. So what the WHO recommendations are is for someone who tests positive for COVID-19 with a PCR test, what we recommend is to be released from either hospital or from home isolation is that their symptoms resolve and they have 2 negative PCR tests 24 hours apart. Now, we realize that that may be difficult in many situations where lab testing may be challenged for one reason or another. So in situations where tests are not available, if you have someone that's home that's a suspect case, that's a probable case and couldn't get tested, what we recommend right now is that those individuals are in home isolation if they can't be isolated in a medical facility until their symptoms resolve, plus an additional 14 days. Now, what we're trying to do right now is look at that 14-day extra period to see if that's something that can be reduced based on available data.
Thank you very much. We have time for maybe another 1 or 2 questions. So let's go to Guatemala now, to Grecia Ortiz from Diario La Hora. Grecia, can you hear us?
Yes, this is a question for Dr. Tedros. Many countries make the use of masks mandatory, including Guatemala. But what other measures must accompany their use, and what are the measures that you, as the WHO, consider vital or important?
WHO obviously advises the use of medical and N95 respirator masks in a healthcare environment, and I think our guidance is quite clear on that, and we want to see that type of material reserved for use in that environment. However, there's been a very healthy global debate around the use of masks more broadly, or face coverings more broadly at societal level. WHO has been clear that there is no specific evidence to suggest that a mask may protect you from infection. Equally, a mask may provide a protection for others. If you happen to be symptomatic and coughing, it might stop you contaminating somebody else. There are a number of issues around the broader use of masks. One, in that it may divert mask use from the healthcare setting, and that's something that just cannot happen. There are issues around wearing those face coverings and disinfecting those face coverings and disposing of those face coverings or masks, and the fact that putting on and off those masks involves people often touching their face as well, and therefore it cannot be done outside the context of very clean hands and proper personal hygiene. And also, masks are not an alternative to lockdown. And we've said this publicly again and again. WHO will support countries who wish to implement a more broad-based strategy of mask wearing or face covering wearing on a broader basis, as long as it's part of a comprehensive strategy, as long as it's linked to the things we said before: community education, personal hygiene, a strategy to find, test and isolate cases. If mask use is added to that, then I think the WHO can see the value. But if mask use is used as an alternative to those public health strategies, if it's used as a reason not to do those other things, then we believe that is the kind of policy that's counterproductive. So we see mask use in the broader context of a comprehensive strategy, and in that sense we'll support member states who wish to introduce that, as long as it does not take masks out of the healthcare environment, and people know how to wear them, know how to dispose of them, and are doing all the other things that they need to do. Maria?
Just to add with the comprehensive strategy that Mike just mentioned, it includes also physical distancing, it includes hand hygiene, it includes respiratory etiquette, it includes staying home if you're unwell, it includes cases being isolated, confirmed cases being isolated, it includes contacts being in quarantine, and it includes following the directives of the national governments if there are stay-at-home orders in place, and of course overall having an empowered community to know what they can do to protect themselves and their families. So as Mike has said, it's part of a comprehensive approach. It cannot be used alone, but we support governments in making these decisions, and in our recent updated guidance we've put some considerations that they may take into account when making these decisions. For example, if physical distancing is not possible in certain communities or certain populations, perhaps the use of a face covering or a non-medical mask may be useful there. And so we, like Mike says, we support these decisions being made, but as part of a comprehensive approach.
And if I could just supplement, one of the consequences we really don't want to see happen as lockdowns are eased, there'll be, there is huge pressure on people to go back to work, to go back to school, to participate in daily life. I don't want to be the person at home with a fever and with a job to go to where I can make a calculation that instead of picking up the phone and phoning my health provider or phoning the public health authorities and asking for a test and a diagnosis, that I think that putting a mask on is an adequate response to that situation. And that is something we really have to be careful about. You may be inadvertently sick, you may not know, but it's something we have to think about very, very carefully. And that's why everything we do in public health or in policy affects something else. So the pressures on people to go back to work are going to be very strong and very appropriate. But we don't want people having to make difficult choices and in some way think that putting a mask on is the same as staying home and reporting the fact that you're sick to authorities.
Thank you very much. Let's see if we can take one more question. Stephanie from Reuters. Stephanie, can you hear us?
Yes.
Please go ahead, Stephanie.
Yes. Thank you. Can you hear me?
Yes, please go ahead.
Thank you. Regarding Yemen, please, I wondered what kind of data you're getting from Yemen. There was a case reported on Friday in Hadramaut in the south. I wondered what you're getting in terms of information on contact tracing. It appears that the neighboring provinces have closed the borders. So I wondered if you've had any suspect cases anywhere else in the cities of Yemen, Aden or Sana'a or Sada. And what sort of capacity does Yemen have or not have in terms of hospital beds, medical professionals, etc.?
Stephanie, we'll have to get back to you on that. We actually had a conference call with our country representative there, and I just don't have that data with me. There's been a huge amount of work going on to prepare isolation facilities, train contact tracing teams, and establish the lab. And as you indicated, the lab there confirmed the first case. What I don't have is the number of suspect cases that have been detected. We only have the confirmed number here at global level, but we will certainly get that. Your concern, though, is correct. The situation in Yemen has a collapsed health system, a very fractured health system, and a hugely vulnerable population. And the UN system is working with all sides to try and ensure that the surveillance systems that we have in place for polio, that we have in place for cholera, that we have in place for other diseases are now being fully activated to detect any suspect cases of COVID-19. Clinical care, many health facilities are destroyed in Yemen, and WHO with partners has been delivering health care through adapted clinical pathways over the last number of years. And we will be able to deliver supportive care to patients with suspect COVID-19 and potentially medical oxygen. Ventilation is going to be a huge challenge. It's going to be a major challenge, and not just the ventilators, but more the technicians to run those ventilators. So we're also looking at how we can provide critical care to people. We do this in trauma care in Yemen and in Syria and in Iraq, and WHO with partners runs major clinical pathways for very high impact trauma in many countries, and we will attempt to do the same in Yemen. But it's not easy, as you say. It's a very large country. It's a very fractured health system, and one in which we will all struggle to provide the adequate levels of supportive care to people should the disease take off in this community.
Thank you very much. So if we all agree, can we have one more question, DG? And before we wrap up, let's go with our friend Jamie Keaton from Associated Press. Jamie, can you hear us?
Yes, Tarek. Thank you. Thank you very much. Let me just scroll back to my question here. Thank you very much. We're trying to. Oh, jeez. Hold on one second. Bear with me 1 second. Okay, so how much? What my question is really about travel and about why we're seeing this outbreak in urban centers more than we are in rural areas. And I just want to see if you've got any new metrics on those fronts. So how much does the fact that people travel so freely in places like Europe and North America with high-speed trains and cheap flights and whatnot explain why this has spread so fast to some countries? And conversely, might it be a saving grace that some parts of Africa and elsewhere are so remote, which would explain why they don't have such high rates? Thank you.
Very good point, Jamie. And I think this morning our teams were actually talking to ICAO and IATA around that same issue, around examining travel flows and how the epidemic. And certainly, I think what it reflects is, regardless of the country, all urban centres are connected around the world now. So we have a global network of urban centres, and at any given moment, you're no more than probably 1 or 2 flight connections from any other place on the planet. But that is very much centred on high-density urban environments around the world. It's almost, it's amazing to see that. And you're right, then disease then penetrating from a national, urban, highly populated centre out into the periphery is a factor of the number of people who go and come. It's a factor of how much distance and social contact there is between people in those environments. But it's also a factor of, can you see that disease? Because very often rural areas may have less sensitive surveillance systems. They may have less health services, and that's a factor as well. So is it that it's not there, or is it that we're not detecting the disease when it is there? And that's something we need to think carefully about. But there's no question that the global urban hubs that are connected by so many connections allow disease to move. How it then amplifies in those urban settings is a factor of population density. It is no surprise that the disease exploded in places like New York City, or first London became the epicenter in the UK before anywhere else. In Italy it was slightly different, but it did centre around urban centres in northern Italy. I think it was the same with in Spain and in other places. So yes, you are correct, and it does mean for the future that we really do need to look at urban health and public health in urban areas, and surveillance and containment in urban areas. Again, I've been positively surprised in many ways in that it's been see how urban populations have actually complied with and bought in to measures that you would not imagine people in urban settings would normally buy into. The idea that people in some of the most cosmopolitan cities in the world have really stayed at home, to me, is a credit. And you would have imagined that would have been much more difficult. and in that sense, I see hope for the future. But your point is well made, Maria. I don't know if you have any specific points on this.
Yes, just to add that even though we have seen some explosive outbreaks in urban areas by the sheer fact that people are living in much closer quarters to one another, and this is a respiratory pathogen that spreads by droplets from people who are in close contact to one another, and also through contaminated surfaces. And so if you have people who are closer together, you have the possibility to spread it. But it doesn't have to be that way. So we have very large urban centers that haven't had explosive outbreaks. And the difference is back to this fundamental approach that we've been talking about is if you know where the virus is, and if you are able to test those individuals, you can actually isolate them and you can quarantine their contacts, and the virus doesn't spread. So just because it's an urban environment and just because a virus shows up in a very densely populated city, it doesn't mean it has to have an explosive outbreak. So there is the possibility that this virus can be controlled. This is the first pandemic in history that we are able to do this. And so it is really critical that even those initial cases that come in, anywhere in the world, and there's a number of cities right now, there are a number of countries that are still seeing low levels of cases, you still have the possibility to control this. And so the quicker that can be done, the more aggressive action that can be done as soon as possible, the better the chance will not see that exponential growth and that outbreak taking off.
Thank you very much. We will conclude with this. And we will see you again on Wednesday. We will have audio files sent to you, as we always do, in next hour or so, with other news from other WHO offices. And then hopefully the transcript of this press briefing will be posted sometimes tomorrow. Thank you.
Okay, thank you. Thank you, Tariq, and thank you all who have participated, and see you in our next presser.
that whole point about asymptomatic transmission, which is to find new ways to fight back against the coronavirus. And look, this is who we are. This is a place where we believe in getting things done. And I have challenged the members of my team to do things that were previously not doable, not thinkable, but now have to be in light of the crisis we're facing and all the problems our federal government to respond, getting the markets all over the world to be reliable, all the challenges we've faced, trying to get the supplies we need and the help we need. Technology sector. Over these last years, more and more capacity growing in this city. And it's allowing us to do things that before would not have been So let me start with the crucial supplies that we depend on to protect us and our first responders, the personal protective equipment. I've taken several trips out to the Brooklyn Navy Yard. I've tried to show all of you what's happening there. But what I first want to tell you about today is that this work is now being supercharged. The face shields, which are so crucial to keeping our heroes safe, started modestly. People in the Brooklyn Navy Yard making the face shields by hand with the components they could get, a wartime factory conditions. I told you a few days ago on Sunday that when it came to face shields, we really need them, but we only had enough to get through this week when you look at all the hospitals of our city. But now we are having a real breakthrough. The companies that came together have now been joined by. Now we have 8 companies in the Brooklyn Navy Yard, the Brooklyn Army Terminal, and in Manhattan, all working together to create the maximum number of face shields for our heroes. They started very modestly, but now they can produce 240,000 per week. That will grow to 465,000 per week by Friday, April 24th. And then the goal soon thereafter will 620,000 face shields per week right here in New York City, made by New York City workers and New York City companies. That is enough to reach the crisis standard we're working under right now. What this means is we will be able to fulfill our entire need for face right here in New York City. Now, we're going to keep working to get more outside, obviously. We want a bigger supply. We want to make sure we're secure for the future. We want to someday move off that crisis standard and go higher to an even better standard. But so long as we're in the middle of this war, so long as we're fighting the coronavirus in the kind of crisis dynamics we are in now, for the first time with something as important as face shields, one of the major PPEs, we're going to be able to say we are self-sufficient. New York City will be self-sufficient. We will no longer be at the whim of either the federal government, the international markets. We won't have to import things from overseas. We will be self-sufficient. That's the first point. The second point, surgical gowns. Now, we need a huge number of these every week. This is an area where it's not possible yet to be self-sufficient, but where we're making huge strides. Again, on Sunday, I told you this was an area I was deeply concerned about, where we had enough to get through this week, but we couldn't tell you yet about next week. We're moving to get major supplies in from all over the country. So this is an area where we do see some relief coming. But again, we will be best off if the most possible surgical gowns are made right here in New York City. 5 companies are now participating in this effort to protect our heroes. They're in the Brooklyn Navy Yard, they're in Sunset Park, they're in the Garment Center in Manhattan, and in Long Island City, Queens. They're currently only 1,000 per week, but by next week that will go up to 100,000. Soon thereafter, we want to get to 250,000 surgical gowns per week, and then we're looking to go even farther. So this is an area where we're going to make a lot of progress. These are particularly important to protecting those who are saving our lives. Another great example of New York City ingenuity and the speed with which New Yorkers can move. Both these items I just told you about, face shields, surgical gowns, in recent memory, made in New York City. These are brand new production lines created from scratch by companies here, by New York City workers, in an atmosphere crisis, and they've surpassed any possible expectation we could have, and they're going farther. But look, and so deeply concerned about the PPEs, and we're going to be concerned about them until this crisis is over, because they mean protection for those who are saving our lives. The number one issue from day one has been testing. When we started fighting the coronavirus here in the city, we said we needed the federal help with testing. It never came. We have scoured the world looking for test kits on the open market. It's been extraordinarily frustrating. We've had so many good people searching everywhere just to buy the test kits to get a reliable supply. It has not been possible. So over months now, the place we turned to for help, Washington, D.C., we never got a straight answer. We never got a consistent. And we wondered, when would the day come that we could actually get the test kits we need so we could start on that road that I talked about a few days ago, from this widespread transmission of the coronavirus to low-level transmission and eventually no transmission. To get there, you must have testing in large quantities. And we knew that as recently as yesterday, we did not know when and where we would get those test kits. Now, one breakthrough on the open market and then another breakthrough right here in New York City, and I'm so excited to tell you about this. Our friends from Carmel, Indiana, I talked about them a few days ago. They donated test kits. A biotech firm there donated test kits to us. But now they have confirmed they can produce them regularly for New York City. So on top of their donation of 50,000 kits, which we're so appreciative for, Diagnostics, Carmel, Indiana, is now going to be producing test kits for New York City. We will be purchasing them starting Monday, it's coming Monday. We'll be purchasing 50,000 full test kits per week from ARIA Diagnostics. I'm sure New Yorkers wouldn't have thought that the cavalry would come from Carmel, Indiana, but it has. This is going to be a big piece of the solution. Going a whole lot more, I want to be clear, because to really get to that point where there's no more transmission, we're going to need a huge number of test kits. But even being able to know we can rely on 50,000 a week from a supplier that we believe in, that's going to be a major, major step forward for this city. I want to thank Mayor Jim Brainerd of Carmel, Indiana, who I've gotten to know over the last few years very well at the U.S. Conference of Mayors. He and I are on the leadership of that body, and he has been an extraordinary friend and ally and really stepped up for New York City. So, Mayor Brainerd, again, thank you. Thank you to everyone in Carmel. Thank you to ARIA Diagnostics. This is a big step. So, that's 50,000 per week, but we're going to need a lot more. And remember, a test kit, and I talked about this a few days ago. I used the analogy of a cup of coffee with cream and sugar. You need the coffee beans, you need the water, you need the cream, you need the sugar, you need the coffee mug. Putting together the full test kit takes three basic components: the nasal swab, the liquid solution, that's what you keep the sample in, it's called the viral transport medium, and a tube with a screw top, the sample secure and sanitary. You need all three of those things to perform a test for the coronavirus. And then, of course, you have to get that test to a lab that then processes it. So we're talking right now about just collecting the test itself from an individual. A whole other part of the equation is continuing to increase the capacity in labs to process these tests and give us the answer person by person. Again, we're going to have to do that on a mass scale going forward. But to get these three parts together so you can collect a test from someone, well, you can't get to first base unless you have the actual test that you can collect from people. So needing those three pieces was crucial. Again, our efforts to get them consistently from Washington, D.C., no result. Our efforts to get them from the open market never could get a reliable partner until today with ARIA Diagnostics. So as we went through these last days and saw New York City companies stepping up, our local government, particularly our Economic Development Corporation, bringing partners from the private sector figuring out how we can do surgical gowns, figuring out how we can do face shields, starting to figure out other equipment that we need to build. And we'll have announcements on that too. Constantly figuring out new ways to support our hospitals and get them the supplies and equipment they need. More and more, what's happened is our team here at City Hall, Economic Development Corporation, and companies, and even universities now, all talking about what can we produce here? How can we do it more and more? How can we do things in New York City? So just a few days ago, people started saying, wait a minute, if we can make all these other things, could we say, no matter what's going on in the international market, no matter what's going on in Washington, could we actually make the test kits here? There's nothing like it in New York City being made right now, but could we make them here? If we just threw in the kitchen sink and tried all the ingenuity that exists in this city. First, of course, we didn't know what the answer would be. We had to pull together a lot of smart people to figure out, could it be done? Could it be done quickly enough quantities that we needed? And we thought about what New Yorkers are facing. We thought about this crisis and what we have to get through. We said, well, if people can make them around the world, why not us? Why couldn't we make them, even if we've never done it before? Companies all over the world could make City on Earth figure out a way. So I'm here to announce to you that we have found a way. And starting in a few weeks, we will be producing here in New York City 50,000 test kits per week with components put right here, with companies, universities, New York City workers right here, building a brand new supply chain to feed this industry that will now develop in New York City. 50,000 tests per week to begin. And if we can go farther, build it up rapidly. It means commercial labs and academic institutions in this city working together to produce that the right way. It means local manufacturers and 3D printers coming together to make the testing swabs and the tubes. Something as simple as those testing swabs, the entire international market has been struggling because those swabs have been less and less available. In fact, a lot of them are made in places that were deep in the middle of the COVID crisis themselves. So the whole international supply was disrupted. But now, through the ingenuity of users, figured a way to make them right here. Production will begin in a few weeks, at the beginning of May. 50,000 a week to begin. Add that to the 50,000 a week from ARIA Diagnostics. We'll have 100,000 full test kits per week that New York City can rely on, 400,000 per month, and that's just the beginning. So we will have to take that new capacity, ensure that there are labs that can handle all those tests and get us results. We're going to need the personnel to administer the tests. We're going to need the PPEs to protect the personnel who administer the test. There are a lot of pieces to this equation. And all the while continuing as a city to make the progress we're making through social distancing and shelter in place. So even while we're building out this brand new capacity as next stage, we will not let our foot off the gas. We will not relent in the successful strategies that are now opening the door to getting out of this horrible crisis. But I want to keep cautioning. It takes all these pieces coming together. Now, the good news, as we see some progress on the hospital front, and we're far from out of the woods, because we see some progress, that's going to give us a little more ability to free up some medical personnel for testing. As we see some progress getting more PPEs, that'll allow us to devote more PPEs to testing. But all these pieces have to come together, and we're still not in a situation where we can say it's going to be easy. It's not. But we need to find a way to keep things, because it's one of the foundations of getting to that next phase. When you get to that next phase, when you get to low-level transmission, remember, then you're able